Welcome to the Night Tube. I'm Stephen Knight and I'm very pleased to be joined by Dr. Soham Das. Soham, how are you doing?
Hello there, Stephen. Very nice to meet you. Happy to be here. How are you doing?
Yes, wonderful. Thank you for asking. I'm glad you reached out and we arranged this discussion because I was just saying to you moments ago before we started recording, mental health is one of them topics that's quite stigmatized in society. People aren't always open about speaking about it, and there's a lot of fear and ignorance towards it. So it'd be great to pick your brains about what you do. So maybe you could start with that. How do you describe what you do to people who ask?
Sure. So I'm a consultant forensic psychiatrist. So to simplify what my work involves, I'd split it into two areas. There's assessing defendants, so defendants who've committed serious offences who either have or are suspected of having a serious mental illness. So, schizophrenia, bipolar, for example. So the first part is giving evidence in their trial, things like psychiatric defences of insanity. I'm sure you viewers would have heard that phrase. And the second part is further down the line. So for the small proportion that needs, so who are too dangerous to be treated in a standard psychiatric unit, they're transferred to these high secure or secure units, and that's another area where I work. So those broadly are the two main areas of rehabilitating mentally disordered offenders.
Very interesting job. So you mentioned schizophrenia there, and there's a misconception around schizophrenia that it's a sort of multiple personality disorder. Maybe you could just clear that up and let us know what schizophrenia is, how does it manifest, and how is it treated generally?
Sure. So you're absolutely right, Stephen. There's a big misconception. A lot of people seem to think that schizophrenia is split personalities. Split personalities does exist as a very, very rare disorder, dissociative identity disorder. Some psychiatrists, myself included, are a bit skeptical about whether it actually really exists as an entity. Schizophrenia, on the other hand, I wouldn't say it's common. So it affects about 1% of the population, but it's very common within my patient cohort, so the ones that make it into the locked secure units.
So it's highly correlated with crime, then? And would you say that's violent crime, or?
It's quite complicated. So I wouldn't say it's highly correlated with crime. It's so the vast majority of people who have schizophrenia aren't violent. They're more likely to be victims of crime. But within the forensic psychiatric unit, so of mental illnesses that cause violence, schizophrenia is definitely up there. So in terms of what it is, it's like a tendency to have periods of psychosis. So a period of psychosis is stepping outside of reality. The symptoms that are most common are things like auditory hallucinations, so hearing voices, or delusions. And in my patient cohort that commit violence, by far the most common type of delusions are paranoid delusions. So the actual deep belief that other people, either people you know or strangers, are trying to hurt you, kill you, harm you, poison your food, etc.
It's fascinating. So, my first question on that really is, it sounds very serious. It sounds like it's a struggle if you're suffering with that. And I suppose I'm wondering, is there any way back from that? Can people have schizophrenia, suffer from it, and then come out the other side with a clean bill of health?
Absolutely, they can. So roughly speaking, about people that have one episode of psychosis will, by and large, recover and won't need ongoing psychiatric care. About a will have schizophrenia and will spend a lot of their time in psychiatric hospitals, and about a third are somewhere in the middle. Because of my specific line of work, so I take from prison or from their court hearings, I happen to deal with the most fortunate third. So I tend to deal with those that don't recover, or they can go into periods of remission, but often they relapse eventually. So it's like a lifelong chronic illness that they have to deal with. So it is very tragic, very sad.
Yeah, for sure. So there's often a confusion between psychologist and psychiatrist. So maybe you could clear that up for us, because I'm not entirely sure myself.
Yeah, that's a bit like schizophrenia and split personalities.
Yeah.
That's another massive kind of misunderstanding within our field. Yeah, so the term gets used interchangeably, but in some ways we're different. So a psychiatrist such as myself, we're medical doctors first, so we have to do all of medical school, all the medical training, learn about all the physical health issues, and then forget it all and never use it again once we specialise in treating mental illness. So we only work with mental illness. Whereas a psychologist works only trains in psychology, so they don't do any general medicine, and they study and learn about emotions. So sometimes there's an overlap with mental illness, but not all psychologists work with the mentally ill. So for example, marriage counselling, confidence building, sports psychology. Those are obviously not mental illness. It's more about sort of emotions and controlling your cognitions and your thought patterns. And the other big difference is that psychiatrists such as myself, we have powers like we can section people under the Mental Health Act. So put them in hospital against their will if they're very dangerous, and we can prescribe medications. Psychologists can't do those things. On the flip side, psychologists generally tend to have more time to spend with their patients. So psychiatrists will have a bigger caseload. We see them occasionally and for short appointments, just like you might see a GP. Whereas a psychologist generally sits with their patient for an hour a week minimum and has one-to-one kind of therapy, talking therapy.
Right. So, I mean, psychology appealed to me when I was in college. I studied it at A-level, and I soon found out it was a very difficult and serious subject. I wasn't the greatest student, but one of the things they really pushed upon you was this idea of the legitimacy of the field compared to how it started. There was always this perception that it was based in pseudoscience, case studies, anecdotal, and it took a long time for it to get the shift towards a scientific field and principle. Similar with psychiatry, there's been a lot of dark days in that field as well in terms of treatment and things that happen there. At what point did the field, do you think, become a scientific, legitimate one? When did it sort of change direction, do you feel?
So I absolutely acknowledge that psychiatry has a dark past, from, ECT to having these asylums where they were just keeping people in cages, almost like as if they were zoos, for want of a better word. So I'm not somebody who feels the need to defend things that have happened in the history. I think that's a difficult question to answer, because if I'm being frank, I think there's a big section of the community who still don't really think that psychiatry is like a legitimate science, including doctors. So I've worked in liaison psychiatry with other doctors, for example, who work in accident and emergency, who make referrals, and sometimes in their language, it's almost like the psychiatrists themselves are stigmatized. And I get why that is. That's because in physical, there are investigations and tests. So there are blood tests, x-rays, there are very definitive certain ways of treating. Whereas psychology and psychiatry is all about measuring of emotions. So it's all very subjective. So I think there's always going to be a perspective where it's not quite as legitimate, and it is more of an art than it is a science. Having said all of that, there are more studies, as you say. Previously it was case studies. You get fairly wacky individual psychologists or psychiatrists like Freud who would come up with these theories and would try and legitimize them only by using their individual case studies, which obviously is not objective. Whereas over the last, let's say from the 70s onwards, there have been regular kind of randomized control trials, so legitimate studies. So yeah, I think the field started turning in the 70s, but I honestly don't think it will ever have the same parity as the other fields of medicine.
Sure. So, I mean, in terms of the public's perception of mental illness, how do you think that is in terms of our consciousness and our the way our society operates? Because it's very much one of them things that's stigmatized. It's out of sight, out of mind. We want to see people with severe mental illnesses behind closed doors, out of view, and sometimes that's for their own safety and the safety of others. But it's also a way of not dealing with the issue. And it's almost like we expect people with mental illness not to be seen or heard. I mean, I was wondering what sort of feeling you have on society's perception of mental illness.
Yeah, good question. And it's a complicated question because there's so many kind of levels and aspects, right? So I'd answer it in a number of ways. The first thing I'd say is that I think in my lifetime or in my career, so I graduated as a doctor in 2003, worked in psychiatry for a few years after then. So within my sort of 15 odd years of working in psychiatry, I've definitely seen a shift in some elements, not all, but some elements of stigma. So for example, 15 years ago, you would have quite clear headlines in tabloids like schizoid killer or psycho killer or, maniac psychiatric patient. Whereas now, the world has become a bit more woke, I think. And in fact, you and I talked about woke, the nature of wokeness, didn't we, on Sean Atwood's channel?
We did. What did you say the new PC term for patient was that they were trying to push?
Service user.
Service user, excellent.
I was making the point that management tried to call patient service users, and from what I could gather, most of the patients could not care at all. Like, they cared about their freedom, being detained, being medicated against their will. They couldn't care less about what they were being called. So I think to a degree, stigma has shifted in that there's certain terminology you can't use. I think celebrities have come out, for want of a better term, with mental illness in droves in the last couple of decades. So, when someone like Stephen Fry came out sort of 20 odd years ago, it was a big deal. It was a brave thing. Whereas now it's quite common. And if you're cynical, which I am, you might even think that some celebrities almost use it as a bit of an angle to try and, promote that they're growing in life. And sometimes it happens to coincide with the release of an album or, a book. So I think in that way, talking about one's mental health has changed for the better, for the positive, even though there might be some cynical reasons. I still think it's for the better. However, what worries me is that I think that people with the more severe ends of mental illness, so I'm talking about the people that I treat and rehabilitate, those with things like schizophrenia, those who end up in prison, those who spend most of their adult life in hospital, I always wonder, where's their voice, where's their representation? Because I don't know of any celebrities that have schizophrenia that talk about being sectioned for weeks or months. So I think that there's almost a kind of paradoxical marginalization of people who are very unwell being pushed even further away and being swept even further under the carpet and being seen as other.
What drew you to this profession then? Because I can imagine it takes a certain sort of character. There's an element perhaps of danger to it. I imagine it can be emotionally draining at times. It's a dark topic sometimes. What made you think this would be a wonderful career path?
This is the point of the interview where I should have an inspirational kind of story about how I was inspired as a child, but the truth is I kind of stumbled into it. I went through medical school, didn't really have any kind of plan of what I wanted to do with my life or my career. I think I was quite immature back then, and I just quite enjoyed my psychiatry placement in my 5th year of medical school. I just remember the psychiatrists being friendly and nice compared to like surgical attachments where they would literally just treat you like a bad smell. So I kind of on a whim, I was traveling around Australia working as a junior doctor in 2005 or 6, I believe. And I was working out in A&E in near Sydney. And then on a whim, I kind of did a psychiatry placement and I immediately fell in love with it. And I think the reason I fell in love with it is because, well, first of all, most psychiatric patients are fascinating in one way or another, whether it's their backstory, which often has tragedy or abuse, or whether it's the delusional world they live in. So they're just extreme experiences from hearing voices to all these unusual beliefs. So that kind of drew me into psychiatry. And then once I started training, when I came back to the UK, there was this thing called forensics, and it was this kind of dark, secretive world that there weren't that many forensic units compared to general adult wards, and it seemed very kind of distant. Even physically, the secure unit was quite a bit further away than all the other hospitals in central London. And I tried it on a whim. I suppose I've always been fascinated with criminality, from gangster rap to gangster films from mob films when I was a kid, and I just tried it on a whim as my very last placement before I had to choose my subspecialty. And again, I fell in love with it.
What's your favourite gangster film? I have to know now.
It has to be Goodfellas, easily.
Beautiful. Yeah. I love it. Yeah. It's my favourite as well.
Yeah, I mean, everyone talks about The Godfathers, and they are good, but I think they're not quite as sort of high-paced. And
you know what? I've still never seen Godfather 3 because I heard it was so terrible. I've just pretended it doesn't exist.
Yeah.
But yeah,
it is pretty bad.
Yeah, Goodfellas is the one, isn't it?
I tell you something that I think is underrated and sometimes not even counted as a gangster film is City of God, the Brazilian film.
Yes, that's a wonderful film. Yeah. I remember watching that at university and it absolutely blew me away.
Yeah, me too.
Yeah, great. That's it. That's all I needed to know. That's okay. We're good now. That's how I always find my way in with people. What films do they love? So, I mean, this idea of delusion is fascinating to me because I spend a lot of time criticising religion, and I'm always wondering where the line is between socially accepted delusions, for want of a better phrase, versus serious medical, or mental illness, rather. So, you mean you may have people who believe things that are on the face of it absolutely delusional, but within a religious context are socially acceptable and not questioned. Where do you draw that line between kooky religious beliefs and a sincere mental issue?
I suppose if you're being technical, then delusions are technically fixed, unshakable beliefs that don't come from an understandable source, that are not in keeping with the person's culture. So that is the technical definition. So if it's in keeping with somebody's culture, so if they either are brought up in religion or they've gone over to a particular sect, then it's not technically a delusion, it's technically an overvalued idea. So overvalued ideas are like diet delusions. So things like anorexia would be an example. So it's not a pure delusion, but it's an odd, almost fixed idea, but it comes from an understandable source. And I suppose that's academic to a degree, but you wouldn't be able to change somebody's delusions with medications if it's based in religion. So if somebody's like a religious fanatic, then that's not a chemical imbalance. It's not like a change from their baseline state, a temporary change, I should say. It could be a change from their childhood. Having said all of that, what I've definitely found in my clinical experience is that religion actually feeds into people's delusions quite commonly, more commonly than I would have expected before I went into psychiatry. So of all delusional patients I see, which I see many of, probably roughly about a fifth have some sort of religious delusions, whether it's hearing the voice of the devil or believing that that they've been possessed by demons, to believing they can hear the voice of God, or they have these grandiose powers or connections with Jesus. So it actually happens quite commonly, and a lot of these people aren't even religious to begin with. I think they just are surrounded. There's so much hellfire and damnation that it's quite an easy kind of topic to absorb into your own paranoid psyche.
That's fascinating. I mean, I often feel that people sometimes confuse really strong ideology with mental illness as well. I mean, suicide bombers are a great example. Now, I'm sure in the Venn diagram there is an overlap with, sincere and severe psychological issues, but it's difficult to explain to people that those willing to carry out those kind of acts aren't necessarily mentally ill, and in most cases, I would argue, are not. I don't know what your view is on trying to explain that to people.
I think you've hit the nail on the head. So my answer would be, it depends how you define mental illness.
Yeah.
If you define mental illness as people carrying out extreme activities that nobody else would think is reasonable, nobody else would even think about, and if they did think about it, they certainly would have the social and moral boundaries to stop themselves doing it. If you think that is mental illness, then everything you've described is mental illness. Terrorism, paedophilia, serious sexual assaults, all those things are mental illness. But that's not how a psychiatrist would define it. A psychiatrist would define it as being out of touch of reality and not being in control of your actions. So a terrorist and a paedophile, typically, there are rare exceptions, but the vast majority, despite them having very extreme kind of possibly right-wing views, they still know what they're doing. They still are in control of their own thoughts and actions. And then finally, the third and probably the most important definition in this context is the legal definition. So the legal definition is insane. You either have a psychiatric defense of not guilty by reason of insanity, or you don't. It's simple, black and white. Psychiatry is a very grey area, but the law doesn't care about that. It's either, it has to be, a yes or no binary answer. So that's the kind of case that I give evidence for not guilty by reason of insanity. And there are, as you'd imagine, lots of jargon and lots of medical criteria. But if you boil it down to its simplest form, the insanity plea is the person have a defect of reason caused by a disease of the mind, so they have to have like a formal diagnosis. But most importantly, either they didn't know what they were doing or they didn't know it was wrong. And it has to be legally wrong, not morally wrong. So 99.9% of terrorists know that they're, planting bombs and the consequences of their actions. And even though in their heads they might justify it, they know it's legally wrong. So almost all of them wouldn't ever reach that threshold to get the insanity defense.
That's a very important distinction. You don't prepare an improvised explosive device on a whim, do you? I suppose. One, just to put it into context. So, one potential exception might be, hypothetically speaking, if somebody had schizophrenia, for example, and they had delusions that the world was going to end and that a particular person or group of people were, for example, evil demons, and if that person didn't make a bomb to kill them, then the entire world would end. That does sound extreme, but that's kind of broadly in keeping with the kind of patients I see. That might be
a situation where you would get the insanity defense, because you didn't know what you knew what you're doing, but you didn't know it was legally wrong.
Right. Okay. Some very important distinctions there. I'm just wondering, is this shaped your perception of free will? Obviously, you're spending a lot of time looking into human behavior and how the mind shapes that. And I operate under the assumption that everything we are and everything we do is a product of the brain, things and processes we're not really consciously aware of. And I often think mental illness, although there are, reasons that can make it worse, drugs, for instance, perhaps a family history, things like that. I always think that it's a case of luck a lot of the time, whether or not somebody suffers from a sort of mental illness or malady. Has this shaped your opinion of, criminals, the concept of evil, the fact that a lot of wrongdoing in that area seems to just be completely out of these individuals' control?
I think so. I'd say a couple of things. Firstly, as I was saying right at the beginning of this interview, there's two parts to my job. The first part is assessing somebody for their court case. So exactly what I was just talking about, whether they get the insanity plea. And then another part is once they've gone through that process, for the small proportion who need to be sectioned to secure units. So the first thing that I'd say is that, to my surprise, actually the threshold to get something like the insanity plea or even to be sent to hospital is very high. It's only a very small proportion of people, even with a mental illness, will go down that route. So you can still have something like schizophrenia or severe depression or even delusions, but you're still held criminally responsible in the law. So I think possibly even ironically, this whole process of me becoming a forensic psychiatrist is maybe more cynical. So even though I do, have a duty to care for patients, and I take that very seriously, I think I've realised that for somebody to not be criminally responsible is actually exceptionally rare. The medico-legal criteria and the threshold is really high. But once people do fit that criteria, so if there are people who literally can't control their actions, they're absolutely plagued by voices telling them what to do, or they fully believe in these paranoid delusions, they are people who are extremely unlucky, probably doubly stigmatized if they've committed an offense, stigmatized for having a mental illness and stigmatized for having committed severe violence or ending up in prison. So for those people, I think there absolutely needs to have a system that exists, the system that I work for, to rehabilitate them and to make them safe. Or the alternative is just keep them in prison, and the vast majority of the time they don't have insight, so they probably wouldn't take medication, you probably wouldn't get better, they'd probably just fester and just stay really unwell for the rest of their lives in prison.
I suppose what I'm trying to get at is I've never struggled with any mental health issues so far in my life, and I don't feel like that's something I deserve credit for. I think that's pure luck, and I think that's always subject to change. I'm not into, I feel like mental illness is something that takes people rather than people choose or bring upon themselves. Obviously there are ways that you can increase your chances, so I'm just trying to get at whether or not you view people differently in light of the fact that we're all just behaving at the behest of unseen chemicals in our brain. I mean, can you look back at some sort of really horrendous mass murdering psychopath, for instance, and think they're pure evil? Or is there a case for saying, well, they were just a product of their brain, they had no choice in any of this? Is there free will? That's what I'm asking, I think. Okay,
that's quite a philosophical question. I think my answer to that would be, which is the same answer to most of the questions you're asking me, is kind of this is multi-layered and complex, and there's lots of different factors. So there are absolutely environmental factors. So my average patient who's committed serious offence, who's got a severe mental illness, almost, I wouldn't say all of them, but the vast majority have come from some sort of social deprivation, poverty, homelessness, have been victims of physical or sexual or emotional abuse. So there's definitely been a lot of trauma and all these outside in their childhood. So if you're thinking, I mean, evil's not a clinical term, it's obviously a judgmental term, but if we're taking that standpoint, then I think it's fair to say that at their point of childhood, like any child innocent, at that point they're not evil. Having said that, some people commit acts that keep them in the cycle of offending. So drug use would be a huge factor. Repeated criminality, when there are opportunities to leave the lifestyle behind, would be another factor. Obviously, it's easier for some people than others. So if you come from, a criminal family, or you're born in an area full of gangs, it's going to be harder for you to get out. Some of my patients absolutely are in that dilemma. But on the other hand, some people do have opportunities to rehabilitate. They go through our system, our wards, get this intense rehabilitation, get occupational therapy, gain qualifications and education, and some go on to do very well, and more power to them. But some habitually rehabilitate. So I think they have free will. Those people in those situations have free will to a degree. I'm not saying that life isn't hard for them. It is. And they don't have some of the privileges and advantages that maybe you or I have, but it's still free will. So if we're looking at through the lens of being evil or not, I think those people, I'm reluctant to use the term evil, but they certainly have the ability to make decisions. So I've not given you a very direct answer, because I don't think there is a direct answer. There's so many different kind of influencing factors from different angles on any one individual.
Staying on influencing factors then, if we look at narcotics and how that affects mental health. I mean, I'm from Manchester. I've noticed over the last 2 years, maybe a bit longer, we've had an increase in the spread of people taking spice. It's usually homeless people where I see it, and it's such a strange drug. I don't know an awful lot about it. I mean, it's been dubbed the zombie drug because it seems to stop people in place. I saw a man in Piccadilly Gardens in Manchester who's, I assume, was on the substance. He was sort of stood up but bent completely at the waist, just staring at the floor in some sort of almost physically impossible position, and he was there for a good hour or so. So I mean, what is spice, and how is this linked into the problem we have with mental health?
So spice is something that I've seen a lot of in prisons. So as a forensic psychiatrist, I work in different environments, in courts, in prisons, and in secure units. So I do one-off medico-legal assessments in prisons quite frequently. And spice is a relatively new phenomenon. I think it's been around for roughly about 5-6 years. And the reason it became popular in prison was simply because it's cheap. It's quite easy to smuggle in, relatively speaking. So it can be made into like a spray chemical form. So there's been cases of people spraying it on kids, like paintings, and using that to sneak into them. But most significantly, it doesn't come up on traditional urine drug screen tests. So I think they've made new tests over the years. The chemists have kind of developed tests to pick it up more effectively. But then the chemists who make these kind of synthetic cannabinoids like spice, it's always like a cat and mouse game. They change the formula. So that's the reason that spice came in. And I can't remember whether I said this, but it's very cheap as well. It's very cheap compared to like cannabis, for example. But to me, it seems like a horrific drug. So like yourself, I've seen people on spice in prison, and like yourself, they don't look like they're having a great time. They're not
having a good time at all, are they? No.
They look completely zombified. So I struggle to understand why. My best guess would be that their lives are so shitty, either in prison or homelessness for the man that you were describing, that they'd rather be in some kind of different space mentally than the reality. So the reality is so bad that being half paralyzed and half zombified just to help time go by is better. So I think that's one big influence. And another one, well, price is always going to be a big factor. I imagine peer pressure is another big part of it as well. If you're part of a prison and there's a hierarchy and a lot of people are taking this drug, then you probably want to be one of the cool kids that gets involved, as opposed to being an outsider that could be potentially seen as a target or a snitch.
Let's talk about cannabis then for a moment, because that was for the longest time in the UK. It was a Class C drug, which would relate to how much trouble you'd get into if found in possession or with intent to deal, I suppose. And then I think it was Gordon Brown bumped up to a Class B drug, which made it a bit more of a serious offence. And there's always been this perception, this public wisdom that it's a harmless drug, that the use of it is far preferable to alcohol and other things. And I have to say I'm a liberal when it comes to drugs in some senses, but I've not always been entirely convinced by this argument that cannabis is completely harmless, non-addictive, and you can puff away and live a healthy and fulfilled life. I just wonder what sort of views do you have on sort of excessive cannabis use?
Yeah, I think broadly speaking, I'm probably a bit like you. I'm generally on the liberal side of the spectrum. Look, if I was going to be blunt, I think that the vast majority of people can use cannabis, and it's not a danger. It's not. There's no risks, or there's very minimal risk. So there's very few of them will have mental health issues. Even smaller number will ever be violent. You know, if there's any risks of them falling asleep on the couch and eating too much pizza. Having said that, I think there is a very small but significant proportion who are predisposed to mental health issues. So those who have a family history, and as I'm sure you know, the genetics of most mental illnesses are complicated. It's not like an autosomal dominant gene, it's clusters of genes. So the reason I mention that is because it's not always obvious. Like, your parents don't necessarily have to have had a mental illness for you to be susceptible. It could be, you know, distant cousins, for example. For a small proportion of people who are genetically susceptible and just have reduced neuroplasticity in their brain, so the neurons can't adapt very well, those people can become psychotic. And I've seen it in my practice, and sometimes it's not that big a deal because it's a short period of time. They learn their lesson, they know that they have to stay away from cannabis, especially the extremely strong forms like skunk. But you also get people who, even despite the fact that they become psychotic, will carry on taking the drug, which just seems completely illogical and ridiculous to me. But I see it. I see patients that go on to commit severe violence and go to prison because they become psychotic when they smoke weed, and they still carry on doing when they get released. So to summarize, I think my opinion is that I think it's safe for most of society, but I think there's a small but significant proportion sometimes who don't even have the motivation and the insight to stop using these kind of drugs. So I guess I think there's a comic, Jim Jeffries, the stand-up comedian, is always talking about we only go as fast as our slowest people. So he was talking about it in gun laws, but you have to have laws because some people's always going to ruin it by doing things insensibly. So even though I'm liberal generally, I also understand that there has to be controls to look after the people that are not sensible enough to look after themselves.
Yeah, I suppose paranoia is something that's often associated with cannabis and THC. Now, is that, I mean, I'm not sure if you know, I mean, it might just be speculation on my part, but is that something that can increase as a consequence of using that drug just to be part of your, a feature of your brain afterwards? Is that something you can create? Can you create that state to a permanent extent, do you think, even after you stop smoking the drug?
Yeah, absolutely you can. So people who use cannabis very heavily, I would stress that it's very heavily, not just people who, experiment once in a while, who use it very heavily through adolescence. Studies have shown that their prefrontal cortexes, so the very front of their brain on both the left and the right side, tends to thin. And that affects things like judgment and memory. So absolutely, there can be long-term effect. In terms of paranoia, there's two different things that can happen. There can be kind of long-term background paranoia, which is always there, regardless of whether they're using that substance or not, which I think is what you're asking about. And on top of that, there are periods, temporary but extreme periods of drug-induced psychosis. So I'll tell you. Do you want me to tell you about a case of drug-induced psychosis?
Yes, please. Obviously.
So I remember seeing a man who was a relatively heavy drug user. This was, I think, around 2016. And he was a gay man, and he was from South Africa, and he just had his grandparents who he was staying with, and they kicked him out of the house. So he was walking around Soho looking for sex, met another man, went round to this random man's flat, and they took something together called a booty bump, which I had not heard of before I did this assessment, and I looked it up afterwards. And do you know what it is, booty bump?
No idea.
It is where you take something like crack or like really strong amphetamines like crystal meth, and you sort of mix it in this solvent. Oh. And you squirt it up your asshole so it goes through your membranes.
Right, I could never have even guessed that. That's took me by surprise.
Sounds kind of enticing until you know what it actually is. So he took that, and he became completely psychotic, like just off his rocker. So he was convinced that the police, that this man that he'd only just met was like an undercover policeman, and the police were about to raid this man's flat and get him arrested. So he was getting really paranoid. He was acting very erratically. So this man kicked him out of his flat, And then he walked just a couple of blocks to his dealer's house. This is all in central London. Got into his dealer's house, bought some more drugs, became even more psychotic. And he was convinced, he locked himself in a bathroom, and he was convinced that there were dragons in the house that were trying to kill him. And he was also convinced that he was on fire. So he gets his phone out, and he texts his cousin, who happens to live about a mile away in London, saying, I'm going to die, I need your help, please come over, and text her the address. So she runs over to help him, and he's so confused and psychotic that he forgot that he texted her. So she turns up out of the blue to his dealer's flat, and he's really suspicious of this. So he thinks that she's part of this conspiracy and must be working with the police. And he was in the bath. He locked himself in a bathroom, and she could hear him screaming from the outside. So she kicked the door down. The dealer is smoking weed all day. He's asleep in the living room. Doesn't know that any of this is going on. He's got music on really loud. And then the cousin kicks the door down, and the guy that was assessing had a pair of scissors on him, and he was fending her off with a pair of scissors, and then he stabbed himself in the cheek with a pair of scissors and put literally a pair of scissors right through the side of his cheek. And he was completely naked. I forgot to mention that, because he'd taken all his clothes off because he thought they were on fire. And his cousin was obviously very concerned, so she was grabbing all his clothes together, and then he stabbed her on the back of the head with his pair of scissors, just because he was so sort of psychotic. So that's a good example of very extreme drug-induced psychosis. And of course, the reason that was interesting for me was whether there was a psychiatric defence of the insanity plea in that particular case. So that's something I gave evidence about.
Never a dull moment, I suppose. So, I mean, it's very interesting that you say that the insanity plea has a very high bar, because that's something that's often thrown around in popular culture. Like, it's so frequent, it's a trope in movies all the time. So what you're saying is that that's something that's not really commonplace, and even when it does happen, there's such a high bar to clear that it's all standard and boxes checked.
Yeah, that's exactly right. And there's quite a detailed process of getting the evidence together to decide whether somebody actually has those symptoms. So you don't just take somebody's word for it, because anybody could, you could stab a rival gang member and then just say that you're hearing voices. That's not how it works. It's not as simple as that. The forensic psychiatrist has to look at all the evidence. So they look at case papers, they look at CCTV footage, we'll look at witness statements for the victims and bystanders and the police who arrested the perpetrator. So you need to piece together a lot of evidence from a lot of different aspects before you put forward that defence. And the reason you need to do that, apart from being the right thing to do, is because you've got another psychiatrist on the other side who's trying to argue the opposite. So you have to have your evidence tightly to make that proposal.
How do you deal with that then, when you have somebody on the other side who it's essentially they're getting paid just to completely destroy your argument and credibility? How do you, first of all, how do you remain calm, and how do you approach a situation like that?
So I would say that it's the barrister rather than the other psychiatrist that would try to attack my credibility. I have to say this is probably slightly perverse, but I love it. It's my favourite part of my job, is giving oral evidence in criminal cases. And the reason is because the first couple of times I was quite flustered, as I think all sort of junior psychiatrists are. But you come to learn quite quickly, or appreciate, that their job is to undermine you and discredit you, the opposition barrister. They actually know very little about psychiatry, and they know very little about the complexities of any individual case, because you've assessed them doing the defendant, that is, in a full sort of psychiatric barrage of assessments, and the barrister hasn't. And I've got training in psychiatry, the barrister doesn't. So the point I'm trying to make is, as long as I stick to my guns, I'm always going to win the argument. And all the barrister can really do is either make me contradict myself, or try and make me look to try and take away my credibility. So, for example, when I was a junior psychiatrist, they would ask questions like, how can you call yourself an expert when you've only done 3 cases and this particular diagnosis, etc., etc. It's different now because I'm a bit more experienced. So, as long as I stick to my guns and I don't stumble over my words, and as long as I am objective, so if I don't know something, I say that I don't know, or if there are more than one perspective in a situation, I say that there's more than one perspective. As long as you do all those things, then it's actually it's almost like a slight power trip being up there, because when you're cross-examined and you do really well under cross-examination, it actually feels really good. It's kind of like a very polite, long-winded argument with lots of jargon that I always win. It's psychiatrists who get flustered or who get really defensive or who are very narrow-minded, who refuse to see another point of view and who don't concede anything. And I've seen colleagues do this. They're the ones who get embarrassed professionally on the witness stand.
When we first started talking about this, you spoke about your interest in it for a completely compassionate perspective. You didn't feel a lot of people were being represented, being spoken about, and that's a wonderful mentality to have. But also, you're an individual. You have your own safety concerns, and I'm just wondering have there been situations where you've actually felt quite unsafe, and what measures are there to protect you at the same time?
Cool. I'm just making some notes so that I tell you all my stories. So. Contrary to what you might expect, Stephen, I actually generally feel quite safe when I'm doing my assessments, generally, because, for example, if I'm going into a prison, when I see the defendant, they know that I'm there to do an assessment to write a report that the judge is going to see. So even if they're the nastiest, most antisocial, cantankerous, racist piece of shit, they're going to be on their absolute best behaviour when they see me because it serves their interests. So the majority of the time, people are on their best behaviour. The exception to that is either when they're so mentally unwell that they literally don't understand what's going on. So, for example, they're so paranoid that they don't believe I'm a psychiatrist. They don't believe that they're legitimately locked up in prison. They think they've been kidnapped, for example, in which case they tend to be on the healthcare unit anyway. And I tend to see them on a 2 or 3 man unlock, which, as you might know, means that they're in the company of 2 or 3 prison officers who'd be kind of surrounding them because they're so dangerous and unpredictable. Or they just don't care about the system, so they couldn't care less whether they get any kind of mitigating circumstances or whether they're so embroiled in the criminal justice system that they don't care. So it's actually quite rare where I feel threatened, rarer than you might think. Instead, what I would say is that when I'm on the secure units, so I've worked in Broadmoor for a short period of time, but most of my training and most of my work has been in medium secure units. That's actually a more tense environment because the people there are detained there against their will, sometimes for months, sometimes for years, and they've got no reason or motivation to be on their best behaviour. That this is literally where they live day in, day out. And if anything, they sometimes have reasons to be quite irritated and annoyed. And sometimes, as the psychiatrist in charge of their care, I'm withholding something, whether that's leave or giving them extra medication or, not allowing them to go on certain groups because of their risk behaviour. So that's actually more of an environment where you can be threatened and it can be tense. Like I wouldn't say it's not completely violent all the time, but you get a hierarchy as you'd expect because most of these men and women come from prison. So, there's prison beefs, there's gang beefs, there are tensions. Then you throw in mental illness into the mix and you have some people who are paranoid, some people who are hearing voices. Things do kick off. Every, I'd say, month or two, there's a fairly serious incident. So in terms of if I've ever felt threatened, I've actually been punched in the face twice in my line of work. And oddly, they were both many years apart, but they were very similar in that they're completely random. I didn't know the perpetrator at all, so they weren't even my patient. They were on the ward when I was there to see another patient. Both times they seemed completely transfixed by me and had these delusional thoughts that I found out afterwards about me specifically. The very first time happened to be the very first time I was on a forensic ward, literally on my first day.
Oh no!
So even though I don't want to propel the stigma of mentally ill people being violent, and I don't believe that, and I wouldn't want to put out that message. Having said all of that, I didn't help the stigma by being punched on my very first day. But yeah, so this man was completely obsessed with me. He had this what we call Frigoli's delusion. So he was convinced that I was somebody from his past, this ex-bully in disguise, pretending to be a doctor. So he came up and basically punched me really hard on the back of the head when I was looking away. And to be perfectly honest, it wasn't that traumatic for me because there was no kind of build-up of tension. There was no threat. I literally didn't see it coming. I don't even remember being hit. I just remember standing, getting up off the floor. So I think I must have lost consciousness. I don't remember being hit at all. I just remember waking up, just being a bit kind of rattled and confused. So even though I did get assaulted, the second time was similar to that. Even though I did get assaulted, I didn't feel too threatened either time. But to answer your other question, so these units are completely set up for dealing with risk, as you would imagine. So, for example, all the doors are locked, staff carry keys, and you have to get your key through like a thumb scanner set of key releases at the door, and you have to have them on belts at all times with big chains so that you don't lose them. And all staff carry alarms, and the alarms are kind of triangulated to wherever you are in the hospital. So if you pull an alarm, then all the nurses from the other wards will come to your aid within a minute or two. And the actual wards themselves are physically, the environments are kept physically safe. So for example, all the furniture is unthrowable. So you have really big bottom heavy chairs and tables that can't be picked up very easily. You don't have glass or sharp objects, and all the interview rooms and clinical rooms will have these huge windows so that the nurses can kind of see that everybody's safe. So so the wards are kind of built to deal with violence.
What's Broadmoor like then? I suppose a lot of people have this, Arkham Asylum kind of picture in their head of what it may be like to walk around there. Is it intimidating?
You know what? I would say that I think it's only fair to say that my time there, so it was a special interest when I was a registrar, which is like a middle grade psychiatrist. So I only went there one day a week for about 7 or 8 months. And I have to say that my time there, it was actually pretty calm and quiet. In fact, it was a bit more placid and a lot more sort of gentle and calm of an environment than the medium secure units where I did most of my other work. And I think that's because the patients there are deemed to be at such high levels of risk. To actually get into Broadmoor in the first place, you have to have committed severe violence, like sometimes even murder doesn't meet the threshold. Sometimes it's like multiple murders. So because of that, it's a really high proportion of nursing staff to patients. Because the patients are in there for very long-term rehabilitation, many have been there for years, some have even been there for decades. So the staff know the patients really well, know them intimately, so they can tell if something's off, compared to, for example, medium or low secure units where there's a much higher turnover of patients. You have like agent staff that come in that don't know people, so they don't have that relationship. So I remember Broadmoor being quiet, and I remember it being huge, so it's just very, very spacious. I think they've actually moved site since I worked there a couple of years ago, but it's like these huge grand, but lots and lots of fences and lots of huge that you unlock. So it looked kind of like a sort of quiet mansion if it was like mixed with a prison.
Wow. Well, in the nicest possible way, I hope I never have to see the inside of it. Circling back round to this idea of paranoid delusions, I'm really fascinated with conspiracy theorists, and I'm also very fascinated with where the line is between conspiracy theories and commonly held misapprehensions about reality versus a serious psychological problem. So, hypothetically, imagine you have some sort of crazy uncle who spends all his time promoting and believing every and all conspiracy theory he can get his hands on.
Do you have an uncle like this?
Sounds like purely hypothetically. I just plucked this one out of the depths of my imagination. And I'm talking like real New World Order stuff. They're all out to get us. Vaccines is a covert genocide operation, etc. But then during the day, this person holds down a job, perfectly pleasant, no violence at all, no red flags, obviously. Where's that line, and what kind of red flags should you be looking for?
Yeah. So I suppose it's a fine line between people who have very extreme ideas out of pig-headedness and stubbornness, or even stupidity. If for example, they have all these conspiracy theories about vaccines, versus people who are actually mentally unwell. And I think there is a big overlap, and there's a big grey area. But if you're asking me how you kind of differentiate or demarcate the two, to me, it's all about functioning. So if somebody is able to function, if they're holding down a job, have a normal family life and have a social circle, then they're almost certainly not going to be detainable under the Mental Health Act. So you're not going to be able to section them. So you're just going to have to see your uncle at Christmas, I'm afraid. So they're not going to meet that threshold to be detained, and so that means you can't force them into hospital, number one, and you can't force medication onto them, number two. You can try and convince them to take medication, and that may. It might help with some of those delusions, might take the edge off. If the dosages are high enough, then it might even completely resolve those delusions. But to convince them they're mentally ill in the first place, and the vast majority of people that you describe would have a lack of insight, is very, very hard. So if they don't meet the threshold, it's kind of irrelevant whether it's just sort of paranoid conspirational ideas or mental illness, because either way you're not going to be able to treat it. It's those people that go above and beyond that threshold when they're a potential danger to themselves or other people that can be treated against their will.
Okay, so you've got a book coming out next year as well, haven't you?
I do, yeah.
Tell us all about what's the premise, how long did that take, or assuming you're not still working on it?
So I've pretty much finished it now. So it's called In Two Minds, and it's going to be out in March 2022. So it's a bit like my YouTube channel. So it's kind of my own cases. So I've talked about a couple of them with you, all anonymized, sort of weaved into, I call them memoirs. It's not really an autobiography, it's more of a memoir. So it's about kind of my time in my sort of 30s onwards of becoming a forensic psychiatrist. I like to think it's quite funny, it's quite quirky. I think it's a very dark topic, and I do talk about a lot of true dark cases, but I try and keep it a bit light-hearted, which is quite a fine line. You got to make sure that the joke is never at the victim,
yeah,
or the perpetrator, but rather about me or the system itself. So it's just about my cases. I mentioned a few high-profile cases as well, and that's it. You should go check it out.
Absolutely. I'll put some links to that in the show notes. I'm sure it's available for pre-order. Soham, this has flown by. It's been fascinating. I could have spoken to you for hours about this subject. Like I say, it's not something a lot of people are well versed in. You obviously know your stuff. Where would you like to point people towards? Where can they find your YouTube, for example? Where can they find more information about you and your work?
So my YouTube channel is probably the thing that I'm putting my most energy into right now. It's called A Psych for Sore Minds, and it's available on YouTube, obviously. So it is a bit like what I was talking about with my book, but it's a bit more informal, shorter, snappier, a bit more lighthearted. And I talk more about high-profile true crime cases. So people, like we talked about Broadmoor earlier. So I've got a series about infamous Broadmoor patients, from like Ronnie Cray to Charles Bronson to David Copeland, the nail bomber. So if any of your viewers are interested either in mental illness in general or in criminality, or the crossroads between the two where they overlap, then there's something for everybody on my channel.
Soham, this has been a pleasure. Thank you for speaking to me.
Mate, it was really good fun. Always love talking about myself and my work. So thank you so much for having me on. It's been an absolute pleasure.